Good afternoon. My name is Brandon Nabors, and today I present New Cities, Old Barriers, Migration and HIV Prevention among African American MSMs in the U.S. South. The U.S. South continues to carry the highest burden of HIV in the country, particularly among Black men who have sex with men. Although PrEP is highly effective, it remains underutilized in its population. One overlooked transition point is relocation. Many Black MSMs move to southern cities for work, education, affordability, or family reasons, yet we know very little about how that move shapes HIV prevention decisions. The purpose of this study was to examine how relocation to the U.S. South shapes PrEP decision-making among African American MSMs. Specifically, I explored how relocation influences PrEP uptake and continuation, experiences of stigma, healthcare access, and social and peer support. We conducted semi-structured qualitative interviews with 19 African American men who have sex with men. Participants ranged in age from 22 to 48 and had relocated to southern cities within the previous 3 years. Interviews were conducted in Atlanta, Memphis, and New Orleans, and focused on participants' relocation experiences, interaction with healthcare systems, perception of stigma, and PrEP decision-making. Participants consistently describe relocation as more than just a geographic move. It was a cultural shift. Many describe encountering intensified stigma tied to Southern religious norms and expectations around masculinity. One participant shared, "There's such a stigma against being gay and Black. People assume you're promiscuous or already have HIV," while others emphasize responsibility and agency in prevention. "For me, it's about responsibility. I still use condoms and get tested every 3 months." These narratives highlight the decisions about PrEP were not about motivation, they were shaped by context. Relocation influenced PrEP engagement through three interconnected pathways. First, Southern cultural context, including stigma and religious norms. Second, healthcare access, particularly insurance instability and limited availability of affirming providers. And lastly, these structural and cultural conditions shape PrEP uptake and continuity. Relocation functioned as a disruption point, sometimes increasing vulnerability, but also sometimes creating opportunities for new engagement in care. These findings should suggest several important implications for HIV prevention. We must address stigma beyond clinic settings, particularly in faith and community spaces. We need to expand access to culturally affirming PrEP providers, and also peer and community networks can be powerful facilitators of engagement. And importantly, relocation should be recognized as a critical prevention window. The key takeaway is this: relocation reshapes PrEP engagement through cultural and structural conditions, not just through a lack of personal responsibility or motivation. Understanding that distinction is essential for designing responsive HIV prevention strategies in the South. Thank you.